In July 1972, a front-page story in the New York Times broke a horrifying reality to the American public. For 40 years, the United States Public Health Service had been tracking hundreds of syphilis-infected black men in Alabama, intentionally withholding the cure. While the initial headlines framed this as a failure to provide care, internal documents reveal a more sinister reality than simple neglect. The government engineered specific mechanisms to block these participants from receiving medical help, which raises a dark logistical question. How exactly does a federal agency successfully keep a highly vulnerable population sick for decades, especially after a highly effective, mass-produced cure is distributed worldwide? To understand the mechanics of this experiment, we have to look at the specific administrative tools, the clinical lies, and the systemic interventions the health department used to turn living human beings into perpetual data points. The records reveal a horror that transcends simple medical error. The government transformed its own bureaucracy into a weapon against the very citizens it was supposed to protect. In 1932, the Public Health Service set its sights on Macon County, Alabama, designing an observational study rooted in pseudoscientific racism. Dr. Talio Fro Clark hypothesized that syphilis caused different clinical damage in black bodies, assuming these impoverished men would never seek long-term treatment anyway. To get the men to show up, the researchers relied on a massive clinical lie. The enrollees were never told they had syphilis. Instead, they were told they were being treated for bad blood, a local catch-all term for various ailments. To maintain this illusion, doctors handed out aspirin and vitamin tonics, disguising them as active medication. But a team of white federal doctors couldn't operate freely in the segregated South without arousing suspicion. So they co-opted the local black medical elite by enlisting Dr. Eugene Dibble and Nurse Eunice Rivers from the Tuskegee Institute. The federal government manufactured false trust, bridging the racial divide to secure the men's absolute compliance. The most chilling logistical incentive came at the end of the participants' lives. To bypass grieving families who were deeply suspicious of post-mortem disfigurement, the researchers secured funding to offer underreal insurance policy. The catch was that this money was only paid out if the family consented to a full autopsy. The agency effectively hijacked the doctor-patient relationship. What looked to the community like a public healthcare initiative was actually a highly organized biological extraction mechanism. By the late 1940s, the medical landscape shifted completely. Penicillin emerged as a safe, highly effective, and universally accepted standard of care for syphilis. Say somebody cure that would ruin their long-term data, the researchers shifted from passive observation to active obstruction. When 256 of the study's participants were drafted for World War II, the Public Health Service directly intervened, demanding local draft boards remove the men from military service so the Army's doctors couldn't treat them. Back home, they built an even higher wall. The agency bypassed federal laws mandating venereal disease treatment, distributed blacklists of the study participants to private local doctors, and specifically barred the men from accessing state-sponsored mobile health clinics. And this methodology wasn't contained to Alabama. Between 1946 and 1948, federal physician Dr. John Charles Cutler led a study in Guatemala where researchers deliberately infected over 1,300 vulnerable individuals with syphilis and gonorrhea. The biospecimens harvested in Guatemala were then shipped back to the U.S. and analyzed in the exact same laboratories handling the Tuskegee tissue samples, involving both projects in a unified research program. Tuskegee stands as one part of a larger pattern. The shared leadership and pooled biological specimens reveal a federal research culture that prioritized the abstract pathology of a disease over the actual lives of the hosts. Despite these blatant ethical violations, the broader medical community read the published progress reports for decades without public objection. Internal critics like Dr. Irwin Schatz and statistician Bill Jenkins formally protested the study in the 1960s, but the health bureaucracy simply ignored them and suppressed their efforts. The fracture finally came through Peter Buxton, a public health disease tracker hired in 1965. Buxton, whose family had fled Nazi Europe, immediately recognized that the deliberate withholding of medicine directly violated the Nuremberg Code, the international ethical mandate established after World War II to prevent human experimentation without voluntary consent. Buxton filed multiple formal protests with the CDC, which were all swiftly rejected by his superiors. Realizing the agency was committed to observing the men until they all died, Buxton bypassed the internal hierarchy completely and leaked the clinical records to the Associated Press in July 1972. The medical establishment proved entirely incapable of self-regulation. It ultimately took a lone external whistleblower, explicitly invoking the horrors of the Holocaust, to force an end to the 40-year experiment. The public exposure caused an immediate institutional collapse, forcing the government to officially terminate the study by November. Shortly after, civil rights attorney Fred Gray filed a massive class action lawsuit, ultimately securing a $10 million settlement and a guarantee of lifelong medical care for the survivors and their families. The sheer scale of the deception forced Congress to act. In 1974, lawmakers passed the National Research Act to legally mandate oversight and prevent federal agencies from ever running a project like this again. This legislation resulted in the Belmont Report, which outlined 3 core principles for medical research: respect for persons, beneficence, and justice. These concepts were quickly codified into federal law as the Common Rule, establishing institutional review boards. In practice, this means that informed consent, the protection of vulnerable populations, and the active minimization of harm are no longer optional ethical guidelines. They are strictly enforced federal law governing every piece of human subject research in the country. The suffering inflicted in Macon County directly birthed the modern infrastructure of research ethics, dismantling the absolute, unchecked authority of the medical paternalism that allowed the study to begin. But the damage of the Tuskegee study didn't stop when the experiment was shut down. Economic analysis shows that the public disclosure in 1972 triggered a sharp, immediate plunge in medical care utilization among Black men, radiating outward geographically from Alabama. This chart reveals the lethal consequence of that withdrawal. The loss of interaction with the healthcare system is directly associated with an estimated drop of 1.4 years in life expectancy for Black men in the decade following the revelation. While the shadow of Tuskegee certainly loomed, modern encounters suggest health hesitancy is often a rational response to current conditions. For instance, in one recent case, a Black professional declined a clinical trial after realizing the researchers were completely ignorant of Black hair grooming needs. This interaction validated a modern fear that the healthcare system still exhibits a systemic cultural incompetence that ignores the specific needs of Black patients. The legacy of the Tuskegee study suggests that medical hesitancy is not merely a passive reaction to historical trauma, but a response to an establishment that has yet to earn full confidence. The burden isn't on the patients to provide trust. The burden is on the biomedical system to continually prove its structural trustworthiness.